Welcome to this explainer put together specifically for all you MRCOG candidates out there. Look, if you're prepping for exams, you already know that navigating clinical guidelines can feel like wandering through a maze. But the FSRH guidelines are an absolute cornerstone of the syllabus. They show up everywhere, from written papers right through to the OSCEs. So today, we're going to rapidly distill the 2017 Faculty of Sexual and Reproductive Health Care Emergency Contraception Guidelines into a really focused, practical, clinical decision pathway. We've translated all that dense source material into clear slides to help you lock down these algorithms, grasp the clinical logic, and honestly, just pass with confidence. Let's get right into it.
On the agenda today, indications for emergency contraception, the gold standard copper IUD, our oral options comparing Levonorgestrel and Ulipristal acetate, managing complex clinical scenarios, and finally, quick starting regular contraception.
Section 1. Indications for emergency contraception. Okay, let's talk timelines. The absolute crucial takeaway here is exactly when emergency contraception, or EC, is actually required after unprotected sexual intercourse, or UPSI. For postpartum patients, that clock starts at day 21. Before day 21, the natural and ovulatory state basically has her covered, so no intervention is needed. But, and this is a huge but, the clock resets way faster in other clinical scenarios. You have to offer EC from day 5 following an abortion, miscarriage, ectopic pregnancy, or uterine evacuation. Unlike a full-term pregnancy, ovulation can bounce back incredibly fast after an early pregnancy loss, which is exactly why that window is so tight. So lock those two fundamental numbers in your mind. Day 21 for postpartum, day 5 for everything else. Now, examiners absolutely love testing failure thresholds, so definitely memorize this table. These are the exact spots where candidates just drop easy marks. If a patient is on a traditional progestogen-only pill and she's more than 27 hours late taking it, her protection is compromised and EC is indicated. But watch out for the formulation. For the desogestrel POP, that safety window actually stretches out to 36 hours before we consider it a missed pill requiring intervention. And for the depot injection, we're looking at more than 14 weeks since her last shot. You've got to know these rigid FSRH cutoffs cold for both your daily practice and your exams.
Section 2, the gold standard, the copper IUD. Whenever we talk about emergency contraception, the copper IUD needs to be the very first thing that pops into your head. Algorithm 1 visualizes the primary decision tree, and it makes it crystal clear. Always consider the copper IUD first. Why? Because it is unequivocally the most effective method, and it totally bypasses variables like patient weight or BMI. Plus, you're instantly providing ongoing, highly reliable contraception. In an OSC, your literal first reflex and the first plan you verbalize should be checking if she's eligible for the copper IUD. It immediately signals safe, guideline-led practice.
And speaking of eligibility, you have to know these criteria flawlessly. A copper IUD is indicated within 120 hours. That's 5 days of the first UPSI in a cycle. But here's the real kicker. It can also be inserted beyond that 120-hour window if you are within 5 days of the earliest estimated ovulation date. That "or" right there is massive. It means if UPSI happens early in the cycle, you might be able to insert the IUD a week or more later, as long as it's still within 5 days post-ovulation. For instance, if UPSI occurred on day 7 of a standard 28-day cycle, ovulation isn't expected until day 14. So always calculate that expected ovulation.
Section 3. Oral ECE, Levonorgestrel versus Ulipristal acetate. All right, if the copper IUD is firmly declined or just isn't appropriate, we pivot to our oral fallbacks, Levonorgestrel, or LNG, and Ulipristal acetate, or UPA. Algorithm 2 is basically your best friend for navigating these choices. The second you move to oral EC, you have to juggle 3 things: the timeline of the USI, the patient's BMI, and any recent progestogen use. If you can trace this specific visual flowchart in your head during a written exam, it's going to lead you straight to the correct multiple choice answer every single time. Let's put these two head to head. The standard 1.5 milligram dose of Levonorgestrel is licensed for up to 72 hours post-UPSI. Ulipristal acetate at 30 milligrams buys you quite a bit more time with a 120-hour window. Both work mainly by delaying the LH surge, thereby delaying ovulation. But, and this is a critical limitation the FSRH is incredibly explicit about, neither one is likely to do you any good if ovulation has already happened. If that LH surge has peaked and the egg has dropped, oral EC simply isn't going to save the day. This is exactly why the copper IUD, which is toxic to both sperm and ovum even post-ovulation, remains so vastly superior.
Section 4. Managing complex clinical scenarios.
Standard presentations are great, but exams thrive on edge cases. Consider this exact scenario that you are highly likely to see on test day. A patient with a BMI of 28 walks in at 96 hours post-UPSI. How does that higher BMI, mixed with a delayed presentation, actually dictate our pharmacological choice? We're past 72 hours, so standard LNG is immediately off the table. But does her BMI change how we view UPI, or is there another avenue? Let's break it down.
The guidelines give us a really nice, clear, stepped pathway for this. For a BMI over 26, or weight over 70 kilos, step 1 is to circle back and try to recommend the copper IUD again. Its efficacy doesn't care at all about her weight. Step 2, if she firmly declines, your default oral option must be UPA because pharmacological studies show it holds up much better than LNG at higher weights. Only if UPA is totally unsuitable, say because of a contraindication, do you move to step 3, which is offering an off-label double dose, so 3 milligrams, of Levonorgestrel. Nailing this hierarchy is absolutely essential for patient counseling and securing full marks.
And speaking of contraindications, there are 2 major scenarios where UPA is explicitly not recommended. First, women on liver enzyme-inducing drugs, like certain antiepileptics. These chew up UPA way too fast, totally tanking its efficacy. In those cases, you offer the copper IUD or that double dose of LNG instead. Second, severe asthma managed with oral glucocorticoids. Because UPA binds to progesterone receptors, it can competitively bind to glucocorticoid receptors, which could seriously worsen her asthma control. This level of pharmacological understanding is exactly what examiners are digging for.
Section 5, quick starting regular contraception.
Okay, we've given the EC, but what about the aftermath? Quick starting regular contraception is a notoriously tricky area. If you give Levonorgestrel, great, you can immediate quick start hormonal contraception that exact same day. But if you give Ulipristal, stop, because UPA works as a selective progesterone receptor modulator. Dumping external progestogens into her system immediately could competitively bind and totally counteract the emergency contraception. You absolutely cannot quick start progestions right away. You have to advise her to wait a full 5 days, use condoms during that bridging period, and only then start her regular hormonal contraception. Missing that 5-day rule is an automatic fail in an OSCE scenario.
97%. This number right here represents the FSRH auditable outcome target. It means 97% of eligible women presenting for emergency contraception must be actively advised that the copper IUD is the most effective method. This isn't just some polite clinical suggestion, it's a rigorous benchmark of quality care and clinical governance. If you aren't recommending it first and actively documenting that recommendation, you simply aren't meeting the national standard. Demonstrating your awareness of clinical governance and audit targets like this instantly elevates your exam answers from good to exceptional.
So, I'll leave you with this to chew on. How seamlessly are you communicating the superiority of the copper IUD while juggling all of the complex variables of oral EC in your actual daily practice? Are you confidently shifting from evaluating BMI and interacting medications to clearly explaining why the IUD is overwhelmingly their best option? Mastering these pathways won't just get you that MRCOG pass. It will literally make you a significantly safer, sharper clinician. Thanks for hanging out with me for this explainer, and good luck mastering those clinical pathways.